Okay, hello everyone. Good morning, good afternoon, and good evening, wherever you're calling from today. My name is Emily Hirata, and I am the chair of ADRA's Health Technical Learning Lab. And we would like to welcome you to our webinar on social and behavior change practices in humanitarian contexts. During this hour, we will learn about key findings from ADRA Yemen's recent SBC work related to health, nutrition, and WASH, showcasing the weaknesses of how SBC is often used and how ADRA has addressed this to increase the quality and impact of SBC work. We are joined by Ragheb Fadhl, SBC Coordinator for ADRA Yemen, as well as Petr Schmied, who is SBC Consultant supporting Yemen. So before we get started, I would like to welcome you all to put in the chat your name, where you're calling from, which organization you're from, whether ADRA or somewhere else. And I do have a few housekeeping announcements as well. This webinar is being recorded, and it will be uploaded to the ADRA TLL YouTube site after it is finished for anyone to view later on as they wish. Please keep your mic muted, except for those that are presenting. However, if you do have any questions, which we do encourage, please post those questions in the chat, and we will try to get to those later on during the Q&A portion of the webinar. Something else to note is that we have both Spanish and Arabic interpretation services available. So if you are in need of those, please go to the top of the screen, and I'm going to walk you through this briefly. So go to the top of your screen, click on those three dots at the top, choose language and speech, then language interpretation, and then finally your language of choice. Just something to note for the Spanish, there are two options. Please choose just Spanish, not Spanish Mexico, just Spanish. And for the Arabic, we are hoping that the connection will stay strong. If it doesn't, I do apologize, but we are hoping that everything will work out with the internet connection. If you would like to view the presentation slides in either Arabic or Spanish, you can also do that as well once the presentation begins. You can do that by clicking on the bottom of the screen, those three dots there, translate slides, and then your language of choice. So without further ado, I would like to hand this over to my colleagues, Ragheb and Petr. The floor is yours. Petr, are you able to share your screen now?
Yes. Hi, everyone. Apologies for the delay. I wasn't able to share my slides and to use the mic, but now it's already working. So welcome everyone to this webinar, and many thanks to ADRA for inviting me to share with you some of our experience with promoting effective social and behavioral change approaches in humanitarian settings. Just give me a second so that I can share my slides, and then I will give the word to my colleague Ragheb. So the slide should be loading, just a sec. So let me first to check. Can you see my slides before I move on?
Yes.
Great.
Yes, yes.
So let me just briefly explain what is ahead of us, and then I will pass the word to my colleague Ragheb. First, I will walk you, or my colleague will walk you through the background of in which context were these lessons generated. Then I will try to explain what do we perceive as the main challenge regarding the way how social and behavioral change is currently used in Yemen, but also in other emergency contexts. And then I will share what we perceive as SBC best practices and some lessons learned. And my colleague Ragheb will then explain what can we offer to you. And of course, there will also be hopefully enough time for all the questions and comments that you might have. Everything that we will be sharing is also documented in this practical publication, SBC Best Practices, that we published a few months ago. I think that Emily can share it later with you, perhaps when she will be sharing these slides. This publication is available in English and in Arabic. So now over to you, Ragheb.
Thank you, Peter. Hi everyone, and thank you for your attending. My name is Ragheb Fadhl. I'm ADRA SBC Coordinator, ADRA Yemen SBC Coordinator. I will give a brief about the situation in Yemen. As you know that since 2015, Yemen has been devastated by humanitarian tragedy affecting all the aspects of life. That's leading a high rate of malnutrition, cholera outbreaks, and daily deprivations. Also in December 2018, 24 million of Yemeni people estimated as need assistance to meet the basic of life. As you know that in Yemen, the situation is very bad, a poor situation, a very low of education. So people need a lot of needs to meet the aspect of life. ADRA Yemen provides multi-sectoral assistance provided by BHA and other donors. Also, 2 of 3 people in Yemen needs aid. Also, we are focusing about SBC activities about high impacts of related to the health, promotion, health, and nutrition, and wash. So our key agents of channel is it's called CHMVs. CHMVs is Community Health and Nutrition Volunteers. Also, our key channels, we did it group sessions, home visit, consultant, and also sharing videos. SBC work is very great around Yemen, where we did a lot of great work in Yemen. That's a brief about the situation in Yemen, and over to you, Mr. Peter. Thank you.
So thank you, Mr. Ragheb, for introducing us to the context in which we operate. Some people would say that in humanitarian context or in emergencies, there is no time for SBC, but in such protracted crises such as Yemen, there is actually plenty of time for SBC. And we would like to show you how over the past several years, we did our best to ensure that our SBC work is as effective as possible. I have had a chance to support ADRA Yemen for the past, actually now it's exactly 4 years. I have worked with Ragheb and with colleagues. So what we will share with you is kind of this condensed summary of what we learned, what we tested in the past 4 years. Let me now explain to you briefly what do we think is the key challenge when it comes to using SBC in humanitarian contexts. First of all, what we can see is that there is a big gap between what I called SBC best practice. It means everything that's included in the guidance, everything that you can hear in different conferences and so on. And then what you see in the field, the realities on the ground, how actually are different behaviors promoted at the community level or mass media and so on. There are different reasons for it. First of all, there are many good SBC practices. There is lots of know-how available out there, like for example on the internet and in all these conferences, but not much of this trickles down to the agents of change, like to the people who are actually sitting or communicating directly with the community members who are supposed to adopt the behavior. So there is lots of general SBC know-how out there. It is just that the people who need it the most, they don't often have it. So there is a big gap. Well, and then what we can see is that there is very widespread belief that educating people and that raising their awareness is the most effective way to change behavior. That people are not adopting behaviors because they are uneducated, and that if we want to make sure that they adopt the behaviors, we just need to give them the required knowledge, and this is what will lead to the desired change. Many aid workers are also used to this traditional approach that is based on just organizing largely top-down education sessions and designing and distributing leaflets, because simply it's much easier to use. You just deliver training, you deliver leaflets, which is also related to the perhaps mindset that is present in the humanitarian context, because humanitarian aid is a lot about delivering. You are delivering food, you are delivering cash, you are delivering health services, but there is not that much emphasis on how well is social and behavioral change done. So as soon as leaflets are distributed and trainings are provided, this is perceived as if what was supposed to be implemented was implemented, but let's say the incentives for really focusing on doing SBC well are quite limited. And then what we can see is that as a result of these reasons, the SBC work at the field level has much lower impact than what it could have. And we can also see that people, like the community members, are then joining their interest in SBC activities simply because they don't find them very helpful. So for us, it's crucial not just focus on doing SBCs, just on implementing activities, but on doing it well. Yeah, this is really the key focus of the SBC work or the key priority of the SBC work that we are doing. So let me now explain to you what do I mean by doing it well. For us, doing SBC well, it means looking at, first of all, what is promoted. So what is the content of the communication? For example, what do the community health and nutrition volunteers are actually saying to the community members? Then how is it promoted? And then last, among whom is it promoted? To whom do we communicate? So, and what we are aiming for is that we want to communicate about the things that are most relevant to the community members in the most effective manner, and we want to communicate with the right people. It means with the people who are supposed to adopt the behavior, but also with the people who influence whether the behaviors are being followed or not. So let's first have a look into what do we do about this topic, what is actually promoted. Our best practices include, first of all, prioritizing just a limited number of behaviors. If we would now sit together and we would start brainstorming all the different health and hygiene and nutrition related behaviors, like everything that people should be doing, we could easily come up with a list of some 50 or 60 behaviors. But as you can imagine, if you ask someone to change or to adopt 50 or 60 of her behaviors, you will not be very effective. So that's why we focus on just those behaviors that based on available evidence that are most effective in ensuring good health. Where we see a big room for improvement, it means that perhaps not many people practice it, and where we feel that we can actually influence the reasons why people don't currently practice these behaviors. So we use these 3 criteria of impact, room for improvement, and feasibility to narrow down the focus of our work. Then the second best practice, which I would maybe like highlight as really the most important practice that we follow already for several years, is that we measure the prevalence of the key enablers and barriers. Let me say it in a simple language. We are looking at what is the proportion of people that are supposed to practice the behavior who experience like specific difficulties or also like specific perhaps like incentives or like motivations that are for practicing the behavior. Because so it means we are like using a quantitative approach. Because if you would rely just on qualitative data, for example, on some results of focus group discussions or in-depth interviews, the problem is that qualitative research tells you what barriers and what potential like enablers are out there, but it doesn't tell you how prevalent it is. So, for example, it happened to me, this in a context of a different country, where there was a certain belief that like pregnant women are not able to eat different, like certain foods during pregnancy. But then when we measure it, like what's the proportion of women that actually believe in this opinion, we realize that it's a very like minority opinion, something that actually most people like don't share this opinion, and that's why it's not worth focusing like on this on such a taboo. So because when we understand what's the proportion of the target group members that like experience certain difficulties, we are then able to focus on those difficulties or those barriers that are experienced by most people. The way how we assess the prevalence of these like enablers and barriers is that we are replacing the traditional CAP surveys with wider SBC surveys. I would like to explain why did I include in this presentation the word inadequate CAP surveys. I know that CAP surveys are very common, but let me illustrate on an example what we think is perhaps wrong or like inadequate when it comes to CAP surveys. So when you have a traditional CAP survey, it's mainly measuring people's awareness of the benefits of the behavior, perhaps to some extent also their attitudes towards the behavior, like whether they are supportive of it or not, and then perhaps like what's the proportion of people that practice the behavior. Yeah, this is the usual focus of CAP surveys. CAP surveys stand for knowledge, attitudes, and practices. So that's why the focus is very like often on awareness and then on the practices. But this is very like narrow point of view, and it kind of supports the opinion that what matters the most is that we are increasing awareness, because the more we increase awareness, then the more people will adopt a behavior. And what we are saying is that this is not enough. It's not enough that we just measure what's the proportion of people that have certain knowledge. We also have to measure what's the proportion of people that experience the difficulties that prevent them from adopting the behaviors. So here are some examples of what else could we measure. We are looking at an example of exclusive breastfeeding. So we know that there is a barrier, actually quite widespread barrier, that some women think that feeding only breast milk is not enough. Yeah, so we want to know, is this something that just maybe like 1 or 2% of women think, or is this something that 50% of women think? If it's something that is very widespread, we know that we have to focus on it. Another kind of barrier identified by the qualitative piece of research was that some women think that on hot days, additional fluids are needed. It's not enough just to breastfeed. You also need to give water to a baby that is like even younger than 6 months. Some women also think that breast milk formula is better, like more nutritional than breast milk. Other barrier can be that women are maybe some discouraged from exclusive breastfeeding. Another barrier can be that women don't know how to address some of the most common breastfeeding difficulties, or they know it, and in that case, it serves as a great enabling factors. Another, again, barrier or enabler, depending on how you look at it, is like what's the proportion of women that are able to access breastfeeding counseling. So we simply like list all the factors that either make it more or like more difficult or easier to practice the behavior, and we measured what's the proportion of people that experience them. Let me share with you the results, just so that you can imagine like how such data can help us. These are results from 2022, so from the last year. So the survey gave us the prevalence of exclusive breastfeeding, and it also told us that 23% of women think that feeding only breast milk is not enough, and it also told us the reason. So we know that this is actually quite widespread barrier, if like 1 out of 4 women think so, and it's something that we need to focus on. We also know that, again, 1 out of 4 women approximately were encouraged by relatives to feed also something else than breast milk, which again like gave us good rationale for focusing also on the relatives. On the other hand, this opinion that some women think that its infant formula is more nutritious than breast milk, it showed that it's almost non-existent, that only very, very few women think so. And that's why perhaps it's not like putting into it like too much of our like resources. The survey also recorded that actually quite a few women, 2 out of 5 women experienced breastfeeding difficulties that made it more difficult to continue with exclusive breastfeeding. It also told us which breastfeeding difficulties were the most common, and that's why we know like what should our breastfeeding counseling focus on primarily. We also saw that there is actually most women are able to access breastfeeding counseling, but we saw that there is still quite some room for improvement. So this told us that again, like increasing the coverage of the breastfeeding counseling services is something that we need to focus on. And then there was another misconception saying that women should not continue breastfeeding when they are ill, for example, when they have a flu. This opinion was out there that yeah, some women think so, but actually our survey showed that very, very few women have this opinion. And again, it's something that we should not focus on, like there is no need to prioritize it. So this is just example of what data you can get when you don't just like measure on focusing, this standard like awareness of the benefits and practice of the behavior, but you actually start measuring what's the proportion of people that experience the barriers or some of the enabling factors. Well, and then what we do with this data is that we make sure that our activities, our messaging, our communication materials are not doing general awareness raising, but are focusing on addressing the most prevalent difficulties or the most prevalent barriers that prevent people from adopting the promoted behaviors. I think that this is really, this is a really big difference compared to the traditional approach that is just relying on doing like kind of delivering standard packages of standard information about the various behaviors. We really focus just on the most common difficulties and on the things that motivate people to adopt the behaviors. Then the second priority is looking at how we actually how the different behaviors are promoted. When I started working with ADRA, I asked my colleagues to take some videos of how community health and nutrition volunteers promote the different behaviors, and then to send me the transcripts of like what was happening in the videos. And what you could see on the videos is that there were like largely like young volunteers just standing in front of like a group of women, and they were like delivering a monologue lecture, just like talking, and there was very little interaction. And so we knew that this is really not the way how adults are learning, especially when it comes to changing their behavior. We knew that like completely different approaches are needed to bring a change. And so that's why we started focusing on the topic, how are actually these different behaviors promoted. So what we did is that first we had to start with ADRA staff. We had to make sure that ADRA staff are not those people who think that raising awareness and just delivering standard education sessions are the best way to change people's behavior. So we were reflecting on, we're doing workshops where we reflected on their own experience with changing some of their behaviors. And we were questioning them whether just having awareness of the behavior and of the behavior's benefits, whether this is something that led to them changing their behavior. Most of the people, they were able to say, no, just having information was not enough. And this was a good start of the discussion why just focusing on knowledge simply and on education is not enough. Then what we did is that we conducted observations of quite large-scale observations of like hundreds of volunteers using standardized checklists that were assessing which of the like effective communication and facilitation methods are the volunteers using. And this help us understand what are the current strengths and weaknesses in the way how the different behaviors are promoted. Then we adapted the Make Me a Change Agent training module, which is really the most common training module on improving volunteers' communication facilitation skills, like that are needed for effective SBC work. It's a great training module. It's only, I don't know if it's weakness, but simply the module is long. Yeah? It has over 200 pages. And if you give like to a future trainer like 200 pages long publication, just many people will find it difficult like to somehow digest it and to be able to deliver the training. So we simplify it quite significantly so that pretty much like anyone who is at least average trainer and was trained well on using this training is able to deliver it. Then we used something that I called, actually, it's not my original idea. It's the name I think came from Sharon Tobing. She called it high frequency, low density approach, which is based on like offering to those people who promote the different behaviors, which can be volunteers, it can be midwives, it can be health facility staff, opportunity to learn frequently, but without kind of imposing on them large amount of know-how. So instead of delivering always like multi-day trainings, which yes, sometimes it is necessary, maybe at the beginning, but then we try to focus just on organizing like frequent but shorter sessions where it was easier for people to kind of digest and to absorb what we try to share with them. So this approach consisted of organizing either monthly or bi-monthly meetings or workshops with volunteers where we discussed just how is their work going, what are the main challenges that they experience, and then we discussed, or they discussed first with ADRA staff. Later, this was handed over to the health facility staff. So the health facility staff, together with the volunteers, are helping them to prepare for the promotion of the next topic. They are discussing how they can overcome any difficulties that they face. And what's great about these workshops is that the volunteers really appreciate that someone is like regularly meeting them, someone is regularly interested in how are they doing, what's difficult, someone is supporting them to overcome these difficulties, and it really has a big impact on the motivation that they have. Then we developed for each behavior a two-page guidance where we listed what's the behavior, why it should be promoted, what are the main reasons why people do or do not adopt the behavior, then what needs to be done so that these, like what the volunteers should do or focus on, so that these like reasons are addressed. And then what are the standard, like let's say, what are the recommended messages that the volunteers should use. So these 2-pagers, they serve like some kind of reminders. Then we used observation-based electronic checklist, where whenever ADRA staff went and like supervise, for example, a group session or a home visit, he or she could just like check everything that the volunteer was doing well or was not doing well, and it was giving us immediate feedback on what's the quality of the group visits and home the group sessions and home visits. And last, we also offer WhatsApp-based support to volunteers so that whenever they face any difficulties or whenever they want to maybe share a good practice that might also help other volunteers, they can do it. They can do it easily. A few more ways how we try to make sure that volunteers are able to promote the behaviors effectively. First of all, quite naturally, we want to make sure that they have the required technical capacities. So we are very grateful for the support that we get from our colleagues from the WASH, nutrition and health teams, because they help us make sure that the volunteers really like understand like technically the different behaviors that they promote. And as I mentioned earlier, we wanted to make sure that all the support doesn't rely just on ADRA, that there is actually decreasing reliance on ADRA. So gradually we started focusing on helping the health facility staff that like are officially kind of supposed to support the volunteers and that actually like do collaborate with the volunteers quite frequently. So we wanted to make sure that they are able to give them the type of support like SBC support that we have been providing. So currently we are at a stage where actually these, for example, the monthly meetings are health facility led, and we just supervise, and if we see that there are any gaps, we can just chip in. Then we also used data from our SBC surveys to decide on which communication channels we will use. So, for example, we saw that there is quite a high illiteracy. That 3 out of 10 women cannot read. So we quite reduce any distributions of printed materials. We also knew that not many people are using radio. So even though some people were suggesting, why don't you use a radio? We just gave them this number. Look, like almost no one is just listening to a radio, so it's not worth the effort. We knew that there is like a growing trend of women using internet on a mobile phone. So actually recently we decided that we will start with using WhatsApp-based video and audio messages that again don't do general awareness raising, but really like tackle specific enablers and specific barriers. And then as you could notice, I very much mentioned that we work with community health and nutrition volunteers. One of the main reasons is that almost all the women, this year actually the number has even increased. I already received the results of the latest survey. We are now, I think, close to about 98%. So almost all the women, they know volunteers. And they also were visited by the volunteers. So we know we have data that the most effective way to reach women is through volunteers, and that's why we invest like so much into their support. Let me now move to the third priority of like how we want to ensure quality, which is focus among whom we promote the different behaviors. So first of all, I guess as many of you, we are also trying to engage the people who influence whether the different behaviors are adopted or not. These are primarily husbands. So we have like dedicated sessions with men. What was important is that this is something that we focus on within the ongoing project, is that the content of the communication to men is really adjusted to how men see their role, what can they like realistically do to adjust it to the role that they play in like the adoption and non-adoption of the behavior. Simply, we cannot just like deliver them like the same for example, messages and the same type of workshops that we have, or the same types of meetings that we have with women. We really have to look at it like completely from their point of view if you want to make sure that it is effective. And related to this, many men, actually, maybe Ragheb could later tell more about it if you are interested in it. Many men are not keen at all to be like attending something that is, for example, called like nutrition session or health session, because what they think is that these are women's responsibilities traditionally, yeah, because they are saying, now I am like, this is not my opinion. I'm just trying to express like how some men in Yemen like perceive things. There is the understanding that like women are mainly responsible to take care of the kids because they are staying with them at home, which also includes like ensuring that they are healthy, that they are well nourished, and so on. And so if you invite them like to a health or to a nutrition session, they perceive that you are inviting them like to an activity for women. And like men, they don't want to go to like women's activities, or perhaps some men do, but many don't. So what we had to make sure is that we are meeting men in places where they naturally socialize and where it is okay for them to also discuss like any topics that relate like to the well-being of their families. Now, okay, what were the key lessons learned from this process, from using these good practices? I divided this slide into results, like what was actually achieved, and then like on the process of using these good practices. We know that the low density, high frequency approach was very effective in increasing the volunteers' SBC skills and in increasing their motivation. The data that we have from observing volunteers really shows quite a clear trend. We also know that community members appreciate the kind of the soft methods, soft communication facilitation methods that the volunteers use. And we also had very good results when it comes to decreasing the prevalence of barriers and increasing the practice of the behaviors or the adoption of the behaviors. We are not in a position to run randomized controlled trials that would really prove that this is thanks to the approach that we are using. But the results that we had, especially now coming from the latest SBC survey that was finished just a few weeks ago, are very good. We had out of 12 behaviors that we promote, 10 behaviors are now practiced by more women. So the results were improved for 10 behaviors. For the remaining 2 behaviors, there was some like stagnation or slight decrease. But the results really of the last SBC survey in terms of people practicing the behaviors was excellent. What were the key lessons related to the process of like how we did things? What we think was really crucial was the simplification of the Make Me a Change Agent module, because it was easier to use, so more people use it, more people understood it. What was also crucial was to measure the prevalence of the barriers and then focusing on those that most people experience, using the electronic checklists that help us understand just what's the quality of the work that volunteers are doing. And yeah, just maybe a concluding lesson is that in such protracted crises like Yemen, like Syria, like actually many humanitarian crises these days, there is definitely time to focus on the quality of SBC, which is also my encouragement to you, like maybe why you might consider like replicating perhaps some of these practices if you like them and if you think that they are relevant to your context. Well, and to make it easier for you to perhaps use some of our good practices, Ragheb will explain to you what are some of the resources where we documented our know-how, our procedures, and we can share them with you. So over to you, Ragheb.
Thank you, Peter. Also, we can offer to you how we simplified and adjusted make me change against module. It's very good and useful for our SBC work. Also, our examples of electronic checklist. Electronic checklist is very good. We give our activities is a very good result. We're using during our home visits and group session activities when we did supervision or monitoring visit around our CHMVs. We follow their weaknesses and strengthened points through our electronic checklist. We get very great impact from this electronic checklist. That's very good. Also, our standard operating procedure for monthly workshop or SOB is very good for monthly workshop that we did every month with CHMVs and leading by health workers. Monthly is a very good activities and give us a very impact to understanding our strengthen for our CHMVs and make very good communication between CHMVs and our health workers. Also, we provide 2 bags CHMVs guiding on different behaviors. This 2 bags CHMVs guidance is very good and describe everything about behaviors to the CHMVs and using during their home visits and group session activities. Also, our SBC survey questionnaires and report. Our SBC survey is very good. We achieve our work and we get the impact from the SBC survey. Questionnaires and report. Also, Mr. Peter did the questionnaires and the report is very good to our work, SBC in Yemen. Also, we can sharing our practical experience with all of you at any time. We will be happy to support at any time as best practice and a lot of things.
So thank you, Ragheb, for sharing not only like these resources with us, but mainly for like leading all the work that was that was presented here. Here on the photo, you can see our SBC team. Ragheb is the SBC coordinator. I work and I'm advising to the team. I work as a SBC consultant. It's a very nice team who definitely, if you contact them, they will be happy to share with you whatever you might be interested in. So thank you very much for attention. Thank you for joining this webinar. And now let's give space to any questions or comments that you might have.
Thank you.
Thank you very much, Petr. That was so informative. And thank you, Ragheb, as well. It was really amazing to see. I think for me, the biggest change maybe between your approach and a traditional approach is the traditional approach is very systematic or standardized, and your approach is very unique for the context. And I really like how you spent a lot of time really understanding the specific context of Yemen. Thank you to those of you also who have asked questions in the chat. There's actually a lot of questions. I'm not sure if we will get through all of them, but let's try. So I'm not necessarily going to ask the questions in the order that they appeared in the chat, but the first question that I'm going to ask you is, according to your experience with other country contexts, how does the high frequency, low density approach compare to other SBC promotion approaches that you have witnessed or experienced elsewhere? Is this an effective approach in other contexts outside of Yemen?
Look, I think you can answer this question even by just asking what would you prefer more? Like if I can give you, so what I see. So first of all, this like this high frequency, low dosage approach, it's an approach for strengthening the capacities of the people who do the actual promotion of the behaviors. So it's not maybe like approach for promoting the behaviors. It's like a capacity building approach. And what I see very often is that, you know, maybe like initial, like a 3 days long or week long training is delivered on the promotion of different behaviors. And then the assumption is that the people who completed this training will be able to use everything that they learned. But I don't know how it works, for example, in your case, but in my case, if I attend like a multi-day training like 6 months later, I remember maybe like 10 or 20% of what I learned. And I think that it's just normal. And so, and what would I actually prefer if, for example, when I'm learning, yeah, maybe I have some like initial, like bigger training that gives me like more know-how, but then I have a chance to like keep kind of refreshing the know-how, keep learning something new instead of just someone assuming that just because I attended this like one big training, I will be able to do everything. So I think that really the effectiveness of this like high frequency approach is good.
Yeah, for sure. It's easy to remember the little sound bites rather than a lot of information. Thanks, Petr. The next question I'm going to ask is, or from the chat, is were men included in the sensitization process? Knowing the context, many decisions are made by men, which makes male engagement vital.
Yes, we have, so like the qualitative data that we had, they engage like both like men and like men and women. And when it comes to the actual promotion of the behaviors, we focus like the organizations both for women and for men. And also in the SBC surveys, just due to budgetary reasons, we cannot have representative samples of like both women and men. But we are asking like women, for example, to what extent family members or even directly like their husbands or partners approve of the behavior. So we also like have data on just to what extent the relatives or men play a role in the in influencing the adoption of the behaviors.
Thanks very much for that, Petr. Another question I've got is, if we want to change from a traditional SBC approach to this approach of SBC, how do you suggest we go about this?
I would suggest that you first maybe read the publication of these SBC best practices, just so that you get an idea of, I'm not saying that like what we did is like the most amazing and the most unique things that exist on the earth, but I think there are some good ideas. So maybe like reading this publication could give you just good idea, some like good thoughts on like how such a transformation can look like. And then I assume that I think it depends like how experienced maybe your team is and how confident you are. Either maybe having someone who can help you like with the transition, like who is able to use like such more like kind of progressive approach to SBC, I guess would help. We are definitely like happy to share with you like all the resources that we have that are maybe showing like how SBC can be done differently.
Thanks very much for
please,
that.
Ragheb, please, if there's anything that you would like to add, please just come in and also tell us what you think.
Thank you. I'm hearing to your answers. Thank you, boss.
Thanks for that, Petr. I'm sure that Emily and the team will be able to make those documents available after this webinar. Another question is, are gender norms identified as a barrier to women's health?
Yes. I mean, they maybe Ragheb, maybe you can first. I don't want to be like always the one who gives the answers, but maybe Ragheb, you can say like to what extent you think that gender norms, you know, like the traditional division of like what's the role of women and what's the role of men, and what like women can do and what men can do. To what extent you think that this is like influencing like the health, women's health?
Yes, okay. Thank you, Victoria, for your questions, and thank you, Mr. Peter. To be honest with you, truth in Yemen, in our country, for example, mothers do a lot in the houses for take care about their children and something like that. So the man is not very good in practices or in attending, for example, group sessions and home visit. So from our approach, we say that our CHMP say to us When we came to the houses, only we did, for example, our home visits and group sessions only for women, and a lot of people don't attend to this. So we are in our SBC approach, we did, for example, some pilot for attending group sessions only for men is from health workers. We'll did this main health workers will did this activities only with the men to, for example, to see our impact, because men is influencer and can support their wife to go to the health centers to practices a lot of that. Also, Victoria, in with Hajim promoter volunteers, also we have a different kind. We have men volunteers and women and female volunteers. And this men volunteers did this activities separated with men, and women did it for women. Thank you so much.
Thank you very much for that. I think that also answers one of the questions that was posted in Spanish about involving men. I'm going to ask a question which has been translated from Spanish. What are the main SBC barriers you encountered, and how have you addressed them? I know this is different project by project, but your experience is important. You're muted, Petr.
Pardon.
Thank you.
It's hard to say because we focus on the promotion of 12 what we considered priority behaviors, and like each behavior has a different barrier. Yes, maybe some barriers might be shared, like lack of time and so on. But the barriers are really quite different. So maybe if you would ask me like for barriers like to a specific behavior, I would be able to explain them, but it's a bit difficult because we might be talking really about like dozens of barriers like related to these 12 behaviors that we promote. Maybe let me just say that what's really coming out clearly from the SBC survey, and what you can also see, like if you read the SBC survey, is that the women that we survey, they have very good knowledge of, for example, the benefits of the behavior, of when they should be practicing or why they should be practicing the behavior. It's like the numbers are very high, like 98% of women are able to tell you, when they should wash their hands, what are the benefits of exclusive breastfeeding, and so on and so on. But they don't necessarily practice the behavior. It means that there are many barriers that have nothing to do like with this awareness of, and that's why these are the barriers that our work needs to focus on in order to be effective. So just to answer your questions, if you would like to see the barriers, just have a look at the report, the SBC survey report, and you will be able to see like all the barriers that we measured.
Thank you so much, Petr. I found this really useful, and I'm sure others have too. That's all we have time for in terms of questions. I'm going to hand it back to Emily now. Thanks, Emily.
Thank you, Victoria, and thank you, Petr and Ragheb, for that insightful presentation, and thank you for all of the questions that came in. I know that there were a lot more that we couldn't answer, and I do apologize. We might be able to go through them and provide some answers in the follow-up email that we send, so please be looking out for that email. But as Victoria said, that is all the time we have for today, because we are drawing close to the hour. So I do want to thank our presenters, our interpreters, everyone who made this webinar possible. We do understand that the Arabic interpretation did have some difficulties, and we do apologize for that. But we do want to thank you all for choosing to attend our event today. We hope you have gained some insightful learnings. As I had mentioned, in the coming days, you will receive an email with a recording of today's webinar, as well as a satisfaction survey. So please be on the lookout for those, and please do fill out the survey. It helps us with future webinars and in making them better. So I would also like to mention very briefly that there is a technical summit taking place in April 2024 in Dubai. And this is where all of ADRA's learning labs will be coming together for an exciting week of learning and sharing. So for anyone on the call who is interested in joining the learning lab, if you are not part of the learning lab, but you are very interested in joining, the invitation is open to you. Shanda is going to be posting a registration link in the chat. We can also include that in the email that's going out to everyone as well. So please be looking out for that. And with that said, I would like to thank you once again for your participation, and I do wish you a warm farewell for the rest of your day, wherever you might be. And so with that, this draws a close to this webinar. Thank you, everyone. Have a good day.
Thank you for organizing the webinar.
Thank you for organizing this webinar, Emily. Thank you. Thank you, Peter. Thank you all.
Bye, everyone.